So my name is Eileen Martin. Thank you so much for that lovely introduction. So I'm just going to continue a little bit. So I work at VCU over on the medical campus, and I have an amazing job. I do a lot of things like every other academic person, but the favorite thing I get to do is work with an amazing team called the OB MOTIVATE program. It's two doctors, me and Dr. Catherine Tyson, who are both OBGYNs and do addiction medicine. We have two fabulous nurses that know a lot about OBGYN and a lot about addiction medicine too, as well as behavioral health counselors through the clinical psychology PhD program here. We work with Project Empower, who focuses on intimate partner violence. The list goes on and on and on of people that we are also recruiting if you ever want to come work with us. Shameless plug there. So what we do at VCU is we run a program. We call it a program, not a clinic, because we like to meet patients where they are. And so what we do is we work out of kind of 3 geographic locations, but we centrally coordinate all the care together. The reason I'm kind of starting my presentation telling you about who I am and who my team is because it's going to make a lot of sense when I give examples later on in my presentation. And so we work under the Department of Psychiatry in the addiction medicine clinic called the Motivate Clinic. If anyone's ever heard of it, it's in Jackson Ward. And then we also physically work in the OBGYN ambulatory or outpatient space. And so we also have a clinic where you walk in just like every other pregnant person, but we have a clinic that's in the same space as everyone else where we can see patients during pregnancy who are also seeking medical treatment for their addiction. And then we also work with the incarcerated populations too. We do go to one jail and we collaborate with multiple other jails, mainly for the pregnant patients. And what we try to do is centrally coordinate their care. So even though patients will traverse during their trajectories of both pregnancy, postpartum, and also their trajectories through treatment and recovery, because those are going to be the patients that we take care of, they're going to be all over the place, right? They might go to different clinics. They might go to one of our jails. They're definitely going to go to the inpatient side sometime, right? Pregnancy ends sometime. That delivery is going to come. And so we collaborate across all those spaces to try to meet patients where they are. And so that is mainly what I do. And this is a picture of our team that we have here. So these are our learning objectives today. So I have 4 things. I'm going to give 2 disclaimers. I had no financial disclaimers, but I have 2 other disclaimers. One is that I'm a physician. I work on the medical side of things. So I work with a super multidisciplinary, amazing team, but my role on that team is the medical side of things. So I might sound a little siloed in my talks today because I'm going to be talking a lot about like medications, things like that. But I recognize that everyone's trajectory and pathway through treatment, if they seek that within a medicalized context or not, and through recovery, is each person's own trajectory and own pathway. What I'm going to be talking about today are particularly about the patients that I see, the ones that end up in my clinic. They came in, they voluntarily walked in the door, and they were seeking the services that my team focuses on. So I might sound a little siloed in what I talk about today, but that's on purpose because that is what I do, my role on my multidisciplinary team, and that is typically also where I get questions a lot of the time. So I'm going to focus a lot on that, but please recognize that I know that I'm one of many people on my team and also on multiple different types of teams depending on where you work. The other disclaimer I'm going to give is that I'm a researcher. I love numbers. I love research. I love studies. Almost everything I say is going to be based on a research study as well as with my clinical anecdotal experience working with hundreds of people through pregnancy and postpartum who are also seeking treatment and recovery. And so, but a lot of our research in addictions has not separated the 2 variables. Again, I'm a researcher of sex and gender. So sex assigned at birth between male and female and gender too. So I absolutely recognize the difference between sex and gender. One is a biological variable and one is a social construct. But our research to date has not caught up, okay, with what needs to be done. That's actually part of my job too, is to focus on educating researchers in the addiction space about sex and gender differences, how we need to do a better job tailoring our research and our clinical care to the needs of the individual patient. And 3 of those things that I focus on, I try to just do 1, but now I have 3 are sex, gender, and social determinants of health, as was mentioned in my bio. So today I'm going to be talking a lot about women. I recognize women, when I'm talking about people who identify as women when they walk into the door in my clinic, but please note that I'm going to be talking a lot in the binary today, but that's just because that's what the hand that was dealt to me, because that is where a lot of our research stands, and we have a lot more work to do in that space. So I'm going to have a job, I'm going to have passion probably for the rest of my career in this area, because there's a lot of change to be done. Okay. So these are our learning objectives. I only have 4, and the first one we're going to talk about is epidemiology. I love numbers, so I warned you about it. This part of the presentation is going to be a little bit different. You guys have probably already seen a million graphs about the opioid, now the overdose crisis, et cetera, et cetera. I'm going to try to just show you the numbers through a little bit of a different lens, an intersectionality lens. When we look at numbers that are separated by sex between males and females, because that's the data that we have, as well as by race and ethnicity too, because those are where the most common disparities that we're seeing on a national scale are coming along. I also talk kind of fast. I didn't warn you guys about that. Okay, so this is we only have 4 main points, okay? Number 1, substance use related deaths are killing more women than the, quote, traditional medical causes, i.e. the things that I was trained in as a physician during my medical training in medical school and in residency. And these deaths are occurring at terrible rates, and they're especially occurring during the postpartum period that I'm going to identify as the year after the end of a pregnancy, as well as among communities of color. So again, this is one of those graphs that I warned you about. So I don't know if anyone knows, but you can go onto the CDC website here, and you can look anytime to look at the drug overdose related deaths. And I like this website. I update it before all of my talks, and I like to tailor it by people's states. So you can look at it by state, you can look at it by drug class. And I also like to look and do some simple math to try to see, gosh, how much have we increased? And so I will say to you guys, I know I'm preaching to the choir, is that the COVID-19 pandemic was terrible for my patients. It was absolutely terrible. I get actually little goosebumps thinking about it, even though I've said that many times, and because I know my patients, I take time to get to know them. I'm not in their shoes. I'm not trying to say I am, but I walk alongside them when they come in my exam room. And the COVID-19 pandemic was really terrible for our patients for many ways. We had some overdose deaths among patients in our clinic who had, unfortunately, had disengaged with us, and we found out about that, just as examples. And so all of my patients were pregnant or postpartum, so think about that for a second. So we all know about the overdose crisis. We all know we called it overdose crisis now because it's not just opioids anymore, right? That we kind of started out with in quotes, when those kind of getting all the hype, and now it's a lot more substances that are related. And then when we're looking at the changes over time, so again, I'm a researcher, I love numbers, so I like to look at rates over time. So of course we can look at the number of overdose deaths, which is kind of the pinnacle example, right, of how bad is the overdose crisis happening in our country. And again, I recognize there's many other outcomes that are important, but that's the one we have, okay, from the CDC. And when we break it down by years and we look at rates of change over time, rather than just today in absolute numbers, and we break it down between male and female people, and we also break it down by the social constructs that we have of race and ethnicity, because again, that's all the data that I have available to me, even though I also recognize the limitations of those constructs. We see that those changes over time are increasing more rapidly among certain communities. So this is a pinnacle paper that came out, again, I'm a researcher, I love data, that came out a couple years ago, looking at trends over time in overdose-related deaths. And we found that at the, quote, beginning of the, quote, opioid crisis, we were seeing that these trends over time were increasing more rapidly among white communities. But what happened over time between 2012 2018, according to this research that was published, is that those trends flipped. And so if we look over time, the trends have been increasing more rapidly among Black populations than they have among white populations, especially that were noted in this paper. And I recognize that all of those terrible disparities that can just continue to widen, especially in the COVID-19 pandemic, are related to downstream effects of systemic and structural racism. I bring this up at the very beginning because it's important to recognize these numbers. Also, as I talk from epidemiology to up here, all the way to the individual patient right in front of me on kind of that one-to-one level clinical care that I'm definitely going to get into, don't worry. It's important to remember these systemic and structural factors that I see and that do exist in my exam room at VCU, as well as in these big papers that are looking at data from a population level. And then the other way, if we look again, these trends over time, and we're looking at the changes over time, again, because that's where you get the most information instead of just one point in time, we also see changes over time if we're breaking it down between male and female people according to the data that we have from the CDC. And so we have seen that even though in one day, more men are going to die from an overdose-related deaths, we look at changes over time, those are increasing more rapidly for women than for men during certain time periods that we've looked at over the last decade. And then if you break it down even further and you break it down by the data I show in this slide and the one together, we can see through intersectionality lens that those two trends that I'm talking about by race and ethnicity and also by sex between male and female people, according to the data that we have, is just exacerbating the disparities that we've already seen over the last decade. Now moving into pregnancy. So, because I cannot help myself, because I'm an OBGYN, that's where my little heart lies. So pregnancy is a period of the life course for many people that identify who are female sex at birth. And so not everyone is going to have pregnancy and postpartum in their life course, so I recognize that, but many people will. And so those are the patients that I see, so that's why a lot of the talk is focused on that population today. And what's really, I was happy that this report came out, but not happy about the findings. So we finally last year got this report out by the CDC. It's our first national level representative report that has come out finally saying that mental health conditions are the leading cause of pregnancy-associated death. I had known this for years. I see it every day, right? And I've been trying to get money, right, from the government to do things, resources from my health system to help my patients, but I didn't have the numbers. I didn't have the report, and now we do. This is really terrible, but I was happy that we finally had the report out so I can actually use that to make change in the circles that I'm in. And so the reason I bring this up is that as an OBGYN, I spent a lot of time learning how to manage postpartum hemorrhage, preeclampsia, hypertensive diseases of pregnancy. What else is up here? You know, all these other things, diabetes, of gestational diabetes. I know all those things really, really well. Those were on my oral board exams that I had to take in order to become a board certified OBGYN. What was not on my exam was substance use disorder. It was not mental health conditions. It was not perinatal depression. It was not generalized anxiety disorder. It was not suicide risk. And these are the things now that are killing more postpartum, especially pregnant, but mainly postpartum people than any of these other things that I was trained in, as well as many of my colleagues in my generation. And I'm not that old, so if you do the math. So I'm happy this report came out. I'm happy I have it, but it's really sad. And it's really, it burdens my heart to realize that this is not just happening in Richmond, as I see it in my clinical practice, and my team does too, but we're also seeing it on a national scale also. And kind of bringing it all together, these numbers, I warned you about the numbers between, and we're breaking it down, right, national level, and we're also looking at the state level, things like that, and we're looking at changes over time between men and women, we're looking at changes over time broken down by the social construct of race and ethnicity, and then we're also looking at the changes over time if we're breaking it down by the life course of pregnancy and postpartum. I know I threw a lot of things at you at once. These are all coming together in our own backyard. So this is data from, I have the luxury of working with some of our state Medicaid individuals here in the state of Virginia, and I've really enjoyed it because they came to me one day and said, Caitlin, I have this database of all the people with Medicaid in the state of Virginia who access substance use disorder treatments within a medical setting, and I have it linked with their baby, so I know when they had a delivery. What do you think we should look at? And I was like, oh my gosh, it's like a Disney World of data. It was really excited about it. My husband made fun of me for being really nerdy, but they came to me and said, what should we look at, right? What should we try to get more information about for the people of Virginia, at least the Medicaid members that we have data on? And I said, let's look at postpartum morbidity and mortality, okay? And let's look at it also by social determinants of health, and let's also look at it by race and ethnicity, because that's what we have in the Medicaid database. So this is an example of some data that we just got published from the state Medicaid data set that we have here between 2016 and 2019, so it does not include the COVID-19 pandemic. Stay tuned for that. We broke it down. Our unit of measurement was the delivery, because that's just the best way to do that in a data set. We can't really do it by individual people because of limitations. And then we broke it down if people had a diagnosis of opioid use disorder. I recognize the limitations of that. There's plenty of people that come through the halls of VCU who have a diagnosis of opioid use disorder if they were to come into my clinic, but just are going under the radar because of stigma and discrimination that they encounter. But it's the best we got according to the data. And then what we did is that we looked at postpartum opioid use-related hospital use. So essentially a proxy for badness is what I've called this. So some type of badness that the person had, medical badness, that they ended up in the emergency room. They ended up in the hospital. Again, a proxy for whatever, for the best I can get with this type of data. And what we found is that, shocker, the rates of these things happening increase in the postpartum period. I knew that, but I wanted to show that it's the same in Virginia, that it is what we've seen from the CDC report. We saw that this is going to be less common among patients, again, this is just opioid use disorder, who are engaged in treatment. So we saw our patients who were receiving medications for opioid use disorder, which I'll talk about more later, that they were less likely to happen in those patients. And then we broke it down if we looked at the intersection between a race that was documented in the Medicaid database and the race and also having an opioid use disorder diagnosis that had been given by a clinician. And generally what we found is that the intersection between opioid use disorder and the intersection with race just kind of exponentially increase the risk of this badness in the postpartum period. So I'm bringing together a lot of things here, but the main point is to say that this is happening in our own backyard. And I bring up these kind of big picture, big numbers, because these are the numbers that, yes, it doesn't really trickle down into the patient when I have this one-on-one conversation, but it gives me a lens to think about things when I read the research, when I listen to the news stories, right? When I hear stories from other people, when I listen to other people's experiences in the medical setting, it's really important to recognize, to listen about these things and interpret them through an intersectionality lens, so we can make sure that we are advancing equity as we're advancing, again, I'm focusing on the medical side of things, addiction treatments, especially for the pregnant and postpartum populations. Number two is that we're going to take a little bit of a step back, because I was told that this was okay to give a little bit of a primer on addiction. Again, I'm speaking to the choir, so it's making me a little bit nervous to do this, because I do this talk to people who don't know anything about addiction sometimes. But people have told me before that they like to have a little bit of the neurobiology, a little bit of review from that. And so the reason that I'm going to bringing this up is, one, because I'm the medical person, so I'm allowed to do this. Don't worry, I'm not going to go through all the crazy neurology. I'm not a neurologist. I'm not a psychiatrist. I'm an OBGYN. So I had to learn all this kind of secondarily myself. And I'm also going to talk about this from the lens of a chronic disease model. I recognize there's many different lenses to addiction, but in my world down the street, that is how I'm advocating for things to happen. When to try to get the anti-bias, the anti-stigma, and the anti-discrimination efforts that I really need to want to get up and going some more at VCU, I need to go at it through a chronic disease model, because that's what we know in medicine, right? We know about diabetes, we know about hypertension. That is how we work. We work in the lens of chronic diseases. That's just how the health system works. So you got to work within the system to make change within the system. So that's why I'm going to review this a little bit. So just going back just a little bit, so you can tune out if you already know this a lot, but as we're talking about people who have developed the disease of addiction, I'm talking about from the neurobiological aspect, what is happening? So let's use methamphetamine as an example, because it is shown in a lot of clinical and preclinical studies, things in like mice and rats and things like that, to have the most most urgent and the strongest impact on the brain. What happens is that when someone is using methamphetamine, I'm just using it as an example, in the beginning stages on the pathway to the disease of addiction from a neurobiological standpoint, what's happening is that they're using the substance, they're having super high levels of these chemicals in their brain that come out that are called neurotransmitters. You might have heard of like dopamine, serotonin, things like that. Those are chemicals that are in your brain that kind of work in your brain to help you feel certain things, have certain emotions, also help you function too. And what happens is that when people are using substances at the beginning of the pathway to the disease of addiction, is that they're having super high levels of these neurotransmitters, more than your brain is meant to have. Your brain is meant to stay in this middle white part area. It's not meant to have the levels of dopamine, serotonin, et cetera, in that green level. And that's where you get some of those euphoric effects, for example. And what happens over time is that your brain is not meant to have that happen to it. And so when your brain gets too much of something, it's neurotoxic. It hurts the brain. Your brain is only meant to have certain levels of these neurotransmitters like dopamine, et cetera, that make you feel, I don't know, warm and fuzzy on the inside when you go on a sunshine day, when you eat a piece of chocolate, when you spend time with your kids when they're, being nice and well behaved, things like that. You're not meant to have the levels of neurotransmitters like dopamine that go into that green level up there. So your brain does not like it. So what happens over time is that with repeated exposure to these supra-physiologic, and I say physiologic like that's what is normal for your body. Supra means way too high. It's neurotoxic. It affects the brain in a bad way. And we've seen this with decades of research that I haven't done, but fancy brain imaging people that I know very well, they do a lot of this fancy research where they look at the brain changes over time throughout this pathway, to developing the disease of addiction. And they kind of see the brain change in certain ways. One, they see the structure of the brain change. So like physically, if you looked at the brain, like what it looks like and how it's structured, that changes. They see changes in the circuitry, so the things that connect certain parts of the brain, kind of the wiring gets mismatched. The most important wiring that I like to point out, especially when I'm talking to clinicians, is the wiring between the reward system of the brain, so kind of that middle, and then that big yellow line you see over there, the reward system that's in the middle of the brain, and then to the front of the brain. Your front of the brain, that's the area of the brain that tells you, oh, that's a good idea, let me go do that, or no, that is a bad idea, I should not do that, that will cause me harm. And that front of the brain is what keeps you in check. What happens over time with the second change, like I said, structure, or now the circuitry or the wires, is that those wires get mismatched. The wires get off, they don't function the way they're supposed to be, and that reward system can kind of hijack and take over the front of the brain. So when I try to discuss with clinicians over on the MCV campus about the disease of addiction and the neurobiological basis, because that's what doctors and nurses, that's how we think about things, I try to really hone in on this fact, because sometimes I say, you'll have a patient come in and they're continuing to use a substance despite adverse consequences, which is the definition of addiction from a medical lens. And your first thought that you might have is, why? Stop doing that. Look at all these terrible things that are happening. And you're like, why are you still doing it? People are thinking that. Doctors and nurses are thinking that, but I have to remind them with the little nugget that I think we'll get through, that this mismatch of this wiring is part of the reason that that's happening. And when you can kind of medicalize it, it can help make change in the medical system from stigma and discrimination. And so what happens over time with those two, the structural changes, the wiring changes, the third part is the receptors. So dopamine receptors, so receptors are like little flags in your system, and that's where the chemicals like neurotransmitters like the dopamine attach to, and it causes its effect. What happens over time is that the dopamine receptors, because your body is trying to kind of change itself, it kind of down-regulates the dopamine receptors. It makes them all kinked and messed up so they don't work as well, because your brain is trying to save itself. It's trying to preserve itself. It's like, there's way too much dopamine. If I down-regulate the receptors, then I'm not going to have as much of an effect of dopamine. So your brain is kind of thinking that and trying to save itself. But what happens over time is that your brain just keeps on making these receptors that don't work anymore. And so what happens is that people can't feel those happy, warm and fuzzy effects with normal things. And so what happens over time with all of these changes is that when people have reached the disease of addiction from a neurobiological standpoint, they are continuing to use substances not to get to that green section anymore, but to avoid the badness, avoid the withdrawal symptoms, avoid the being sick, avoid the badness down here in the red section. And that's a big misperception, especially in the medical community. People think that once they're over here that they're still doing this. I'm like, no. They're over here. Their brain now is like, I can't function, I can't feel normal unless I have the substance, unless I have the methamphetamine. So in order to feel normal, because remember your brain has been hijacked now by that reward system, people are going to continue to use substances despite adverse consequences, because the brain is saying that's the only way that I can feel normal. So from a medical standpoint, addiction, the way that I like to think of it, from a medical standpoint, how you diagnose it, how you treat it, is that it's a brain-centered condition, is what we tell from a medical lens, whose symptoms are behavior. Sorry, that got cut off. Why that's important is that when I say to my primary care colleagues, and I try to say, hypertension, when someone comes in and they get their blood pressure checked, I have a nice little number. I have a systolic blood pressure, I have a diastolic blood pressure. It's pretty cut and dry, right? Diabetes, I can get a hemoglobin A1C. It's a number I get from a blood test. when we're talking about mental health conditions, it's a little different, right? I have to talk to a patient, I have to do a diagnostic interview, and I have to take someone's life story and put it into checky boxes called the DSM-5 criteria. Not the favorite part of my job, but it is a part of my job that I have to do, because in order to do anything in medicine, you have to have a diagnosis. In order to get a prescription for something, I have to have a diagnosis in order to give you the prescription. For your Medicaid to cover your prescription, I have to have a diagnosis. So we use a DSM-5 criteria to do that, but it can be hard, right? You're trying to take someone's story of what they're dealing with on a daily basis and put it into little checky boxes of DSM-5. So I really try to urge other clinical providers to just, I know it takes a little extra time, it takes a little extra thinking than that systolic and diastolic blood pressure that you already got, but you can do it. And we do have the DSM-5 criteria that we do currently use. And the salient feature, like I already mentioned, is the continued use despite adverse consequences. I'll let y'all read this, but this is the formal definition that we have in the medical community of addiction. And this is from the American Society of Addiction Medicine. It's kind of like the big professional society for people who work in addiction medicine or board certified in addiction medicine, like I am. Just to note that any physician can go through addiction medicine fellowship. You can be an OBGYN, you could be an internal medicine physician, you can be any type of physician. And the way that they've done it, they've expanded the ability for people from all medical specialties to now get this board certification, which is really great. I love working at my job at Motivate Clinic because all of us have different backgrounds and we can really work together to try to help our patients and meet their needs. Okay, I mentioned pregnancy. So I'm talking about women, I have to talk about it. So like I try to say, so I think I got the neurobiological basis, check. So just like with everything else, diabetes, hypertension, et cetera, you have a positive pregnancy test. It's not like the diabetes and hypertension just goes away, right? And I have to remind people addiction is not an exception to that. So the point of the next few slides is just to hone in the point, especially when looking at differences between male and female people, looking at how addiction as a chronic disease can extend across the life course. I'm going to be mainly talking about the reproductive life course for female people, mainly because that's just what I do. I'm a gynecologist, so you can't blame me for that. So looking across the life course, and we're looking at the early life course, we're looking at adolescence. This is kind of hot off the press. So this paper just came out a few weeks ago, actually from some investigators at VCU. I actually cried a little bit reading it because it was really terrible data. So just warn yourself if you go to read it. I have all the citations here. But they looked at the most recent data that they had available, and they looked at causes of deaths in adolescents. I think it was 15 to 19 years old. And they looked at trends over time. So of course here they have the COVID-19 pandemic. They have mainly like motor car vehicle accidents, which generally used to be a huge cause of death in this certain age group, in this young age group. And then the most important ones is right here. You see these increasing trends in these two lines of suicide and what they quote as poisoning, which is mainly overdose-related deaths. So we're talking about the life course. These are young people. And many of you in this room might know someone that is affected by the disease of addiction. Maybe it's been affected by an overdose-related death in your family or a friend. And this is happening in the young people in our country. Okay, moving forward, if we look at this middle time frame here between kind of what I call like the 25 to 35 age range, again, I'm moving across the life course. This is another Pinnacle paper, also from VCU investigators. I was not that biased, I promise, and that came out a few years ago, looking at changes in time and looking at our life expectancy in the United States. The big take home from this paper, with all the fancy data that they had that was nationally representative, is that our life expectancy in the United States has gone down. So the average number, on a group level, the average number of years that an individual lives in this country has decreased in the last 50 years. I'm sorry, don't we spend like millions of dollars on research, on healthcare, maybe a little, we can also argue a little bit on the social support side of things. There's a lot of money that's spent. But our life expectancy is going down in this country. Why is that? Well, the major driver is what I've already mentioned. A lot of it has to do with these overdose-related deaths that are happening in young people. So if you look at an average, and a lot of younger people are dying, it's going to bring down your average a lot, right? And so, well, in the text of this paper, if you really go through it, they looked at trends over time, and they did point out in this paper, which I really appreciated, trends between male and female people going up more rapidly for females than for males, especially for things related to suicide, alcohol-related deaths, as well as almost a little bit of the overdose-related deaths. So again, looking at those disparities is quite important. And then moving it towards the very end, also we have to think about people at the latter end of this life course that I have up on the screen. So this is also data that came out last year, I think from the CDC, yep, looking at alcohol-related deaths in women. And so alcohol use disorder is the most common substance use disorder if we look at all the data on national level. People tend to forget that sometimes. I have to admit, my residents, they know opioid use disorder like the back of their hand because they just see a lot of it. There's a lot of bias in who walks in the clinic at Motivate because they know we prescribe buprenorphine, so a lot of people come in for that. So my residents sometimes forget, and I have to remind them, no, it's alcohol use disorder. Do not forget about the alcohol. And then, like I mentioned, that last paper, when they looked at changes over time in alcohol-related mortality, that has been increasing more rapidly for women than for men, despite the fact that more men, definitely more men at one point in time are affected than women. So again, we really need to look at data across the life course, by sex, by gender, and also, I would say too, by social determinants of health. Okay. So now we're going to go to the third point, and we're going to talk about some evidence-based tools. So a lot of this is kind of geared towards a little bit more of a clinical practice, but I'm going to point out because even if you don't work in a clinic, you can be an advocate for change. You are going to talk to people everywhere who can apply evidence-based tools like this in order to increase the recognition and also decrease the stigma and discrimination that surrounds the evidence-based treatments that we have in order to do a better job than what the numbers I was showing earlier. So I'm going to break this down into SBIRT. Does everyone know about SBIRT in this? Okay, this makes it a lot easier than some of the other talks I give. This is kind of the basic teaching that I give my medical students, that I give my residents, that I give my social work students, et cetera, that work with us. And this is a picture from an SBIRT article that came out a little while ago, focused on pregnant people, because we do have to tailor things just a little bit when someone is pregnant, when we ask questions, and also when we do interventions. So just like with anything else, diabetes, hypertension, which we do screening for in pregnancy. If you've been pregnant, you had to take that orange drink. You remember, and drink it to see if you had gestational diabetes. You went to the doctor, your first prenatal visit. You definitely got your blood pressure checked, right? And then you probably got some type of survey about your mood, right? Maybe the Edinburgh postnatal depression survey. So we've gotten better at that one, but we still have a long way to go for substance use disorder. And so what I really need to make sure especially clinical providers understand is that screening, again, in a medical context I'm talking about for a substance use disorder, is done with asking questions. It's not done with drug testing. I'm happy to answer more questions about this at the end, but I feel really strongly about it. Drug testing is going to tell you about one point in time. I think I told you guys earlier, addiction is a chronic disease model. Knowing about what someone used 2 days ago is going to give you no information. It's not going to give you any information about continued use despite adverse consequences. So drug testing is not how we diagnose a chronic disease. It's just one test. You wouldn't take one blood pressure and diagnose someone with hypertension, right? You would want to look at them over time. Just putting out there. So what we use instead are we using validated screening tools where you actually have to talk to someone and ask questions. It's this crazy thing, but you can do it. That's what I tell everyone else I work with. So I'm going to bring up two examples just so you can take these home. This is one example of one that is used for not pregnant people. This is free online. You go to this website here. And so you ask, what is this, 4 questions right here. I'll let you guys read this. And it's just to start a conversation. So we call it a screening because screening is the first step. If someone screens positive, that means that, gosh, according to the questions I asked, you're at high, medium, or low risk, like on the slide I showed before. And it just means if you're at moderate or high risk, I need to do further assessment, okay? And then if you're pregnant, we do have to ask questions a little differently because there's extra stigma surrounding substance use in pregnancy and parenting too. So I always teach my medical students that you want to start the conversation pre-pregnancy and then work your way to the pregnancy, okay? Also, even if someone is, 26 weeks pregnant is coming in and they're not using anything in the last 2 weeks, I still want to know if they, had some type of problematic use with something pre-pregnancy, because I know that person is at higher risk than someone else who doesn't have that, of having returned to that use in the postpartum period. And then I know that is when most of those really bad numbers, those overdose-related deaths, those are mainly happening in the postpartum period, so on and so forth. See an example of how I use that lens from the epi data to bring to my clinical practice. So let's say, again, you screen your patient, you have the high, medium, low risk, all those tools I just showed, they have like fancy scoring systems, but it's pretty obvious when people answer questions, if you actually listen to their answers, if you know you need to proceed to a further assessment. And so the next step is like brief interventions. And so I heard that you guys already did a lot about motivational interviewing, so I'm actually gonna skip this slide. But there are lots of examples online if you're trying to teach other people about motivational interviewing, which is a key component of a brief intervention. And this is an example down here of a video that actually has been, is being publicized on a national level in order to increase the ability for OB providers to provide these brief interventions for patients. So, and in this video, they do the brief interview, they do some motivational interviewing, and they also just talk and they ask, the further assessment is done about the substance use in a non-judgmental, compassionate way. Again, why I'm skipping this, because I think I'm preaching to the choir here. It's non-judgmental, compassionate way to ask questions and have a conversation. That's really the point of this slide. That is the most important part of a brief intervention. And then getting into the nitty-gritty, and this is where I come in. This is where I come in on the team. Again, I work on a team. There's many, many people. My role as the physician, along with my partner, is focused on the treatments. And I recognize there are many types of evidence-based treatments. When I say evidence-based, that means that there's research showing efficacy, some type of effectiveness to improve the outcome that was measured in the research study. I recognize the limitations of that for real life, but it's what I have. I recognize all of these things. Because I am the physician, I'm going to focus on the medicines because that is my forte, and that's usually where I get questions. And so we do have FDA-approved medications for 2 substance use disorders. And so we have alcohol use disorder medications and we have opioid use disorder medications. Remember my disclaimer at the very beginning. Everyone proceeds through recovery in their own path, and I recognize that not everyone with alcohol and opioid use disorder is going to access medications, and not everyone feels like they need medications on their path to recovery. But I'm going to talk about them because all my patients do, and that is what I do on a daily basis, and I do help a lot of people. And so I'm going to focus on opioid use disorder because that's typically where I get more of the questions. The reason why I struck through referral, which is actually part of the SBIRT, the RT at the end, and I wrote initiate, is because we don't just refer out. If you see it, when I talk to my clinical colleagues, I say, if you have someone, let's say you did the screening, you did the brief intervention, you did your assessment, you don't just refer them out, you start something there. It's easy to do that. And nowadays, especially with X-waiver done, we can do that, but I'll talk about that a little bit more. And so I like to bring this up that on a population level, so if I look at a big group of people, okay, on a national level, a state level, whatever level you want to look at, but a group of people, okay, because the research is on groups. When you look at people with opioid use disorder diagnoses that have accessed the medical system, okay, again, remember, this is the population I'm talking about, very specific people who have accessed the medical system, have been given a diagnosis of opioid use disorder by a clinical provider. The people in those big data sets who are provided medications for opioid use disorder, buprenorphine and methadone specifically, that mortality risk is decreased by 50%. I don't prescribe any other medicine as a physician that decreases badness by that much. I actually don't know of any, personally, that have such an impact. And I really hone this in because when people say, well, I don't need to do that, oh, that's for someone else. I'm like, no. We all need to be doing this who have DEA licenses, that are seeing these patients. If you have someone that says that they want that medication, that is something that will help them, and your patient is telling you that, you shouldn't put them on to the next person. We all who can need to be doing something right then and now. And like I mentioned, I don't know if anyone has heard, but the X waiver. So the X waiver was this thing that we had to get as prescribers. So who had a DEA license in order to prescribe buprenorphine. Methadone is dispensed at methadone clinics, but for buprenorphine specifically, we had to get this thing called an X waiver. You had to do all these hours and then submit this paperwork. It was a little bit annoying. It really wasn't that bad, but it was a big barrier to people being able to prescribe. And it was a big excuse, to tell you the truth. I guess this is recorded, but it was a really big excuse. They're like, oh, well, I don't have the X waiver. I can't help you. And I'm like, it's really not that hard. It's an 8-hour online thing. You can just do it whenever you want. But, it is what it is. But that is now gone. So now people really don't have an excuse. So when I go talk to my clinical audiences, this is the slide I'm really going to focus on. Okay, to the people who do have DEA licenses, can prescribe this medication. You don't have an excuse anymore. And then I wanted to ask them, gosh, what other medications do you prescribe? That have such a robust benefit to your patient, your patient's family, and your patient's society? Because I don't know of any. I don't know of any other medicines I've ever prescribed that have such a robust positive impact. Again, when we're talking on the population level, among people that access medical treatment and people who say, I want this medication. And so, like I mentioned before, you can start buprenorphine. This is a couple just very specific clinical things that I have about how to start buprenorphine. It's a little, if you're a clinical provider and you have questions, I'm happy to take them at the end, or you can come up and talk to me, because it does get a little bit tricky sometimes, especially now with fentanyl. Fentanyl is highly lipophilic, which means it sticks to fat in your body and has it can stick around for a very long time in people's bodies. So it is making it slightly more complicated to start buprenorphine, even when I'm in a fancy hospital like VCU Health down the street. But we are figuring it out. And so, because when someone comes to me and they say they want this medicine because they say this is going to help me reach my goals that I have right now for my treatment and recovery, I say, yes, let's get this going, and we'll figure out how to do it later on. Okay, so the last point I have is related to things that we can all do about to advance equity, which I think I made the point across earlier at the very beginning, and also to advance just the care, the compassionate, trauma-informed, recovery-oriented care that we severely lack in the medical system. And there's a lot of work to do. I think I'm hopefully motivating people. There's a lot of work to do with all those words I just listed. And so instead of me talking, I was not able to bring one of my patients with me today, but I do have a video from one of them that her words are better than mine.
It's important to talk about increased stress postpartum. Some reasons for increased stress postpartum could be having additional responsibilities at home, bringing a baby into a house where you're already taking care of other children, feeling overwhelmed with these new responsibilities, taking care of yourself and your new baby, not having as much help around, lack of sleep, and lack of good nutrition. All of these things can contribute to increased postpartum stress.
The most challenging parts was doing things on my own. I was worried, was I gonna be able to function? Relapse was a thought because it's so much, like, it's first you by yourself, then boom, a new baby. So that was kind of challenging. Definitely relapse, because a baby can be a whole lot.
Increased stress postpartum can lead women to use alcohol or drugs, even if they don't intend to, even if they don't want to, and even if they never thought they would use after their pregnancy.
At first, when you're pregnant, everything is being catered to you and how you feel and your thoughts, just basically your needs. But once you have a baby, everybody is like, oh, the baby's so cute, or they forget about you, like you are X'd out. But you still have to have a support system, like your doctors, counselors, just people that you could go to and talk to. And sometimes they will ask you, how are you doing, before they ask about the baby.
It's normal to need support after you give birth. One thing that could be really helpful is identifying those supportive people in your life that could help you when the baby comes home, a family member, a friend, someone from a support group that you're in, church members, even a trusted neighbor, someone who can sit in your house for an hour with your baby while you take an uninterrupted nap, a shower, or a walk. It's important to also identify someone who's supportive in your addiction treatment and recovery, someone that you can call if you need someone to talk to. This is all a great idea to do now while you're pregnant. That way, when you come home, you'll have people to lend you a hand.
It feels good being able to have that support, but that's the main thing. You have to have a support system, because if you do it by yourself, definitely after like being in recovery, when things hit the fan, it's like, oh my God, I got all this stuff coming to me. And you know, sometimes you might lose focus and feel like, oh, I need to do this, but that's when you could call your doctor and get the extra help you need. It would be scary, but then I'll talk to my mom if she was at home and let her know, like, look, I'm feeling this way because I can't do this. Or, you know, I always ask my mom, do you think I should up my medicine, because having a new baby and dealing with postpartum, it can affect your Suboxone. It does make a difference, or whatever. Maybe if you're on methadone, you might need to up your dosage because the baby really irks your nerves. Like, the baby will irk your nerves, and just everything seems to bother you. So that helps. Like, that Suboxone makes a difference in your cravings, because I think it's just something in your head that might be like, look, you need to use, because this ain't enough. But you gotta overcome that with talking and, like I said, talking to the doctor, getting the help you need.
It's important to make taking care of yourself a priority, even with all this extra stress and responsibility for you and your baby.
Yeah, but that first day home, your baby's gonna cry a whole lot. It's gonna be, you might as well sleep during the day, be up all night, because that's what's gonna happen. Yeah. Get that rest. If your family offer it, or, you know, your spouse offer you the rest, do it.
Great. So I'm going to end on, thank you, Leah's note of the advice to give. And kind of note to, I've mentioned this many times, I showed you a lot of sad numbers. I kind of aired my grievances, some of my frustrations in advancing change in the systems that I work in, and the systems and also the society, the systemic and societal issues that we deal with. But I can tell you right now, and there's research to back this up, that the number one barrier to people getting the evidence-based treatments that I talked about, for people who do want them, is not the lack of buprenorphine prescribers. I get really frustrated about that, okay? I tell the Medicaid people all the time, you can have 1 million of us with X waivers when we used to have it in the state of Virginia. But if you don't get rid of the stigma and discrimination that surrounds addiction and its life-saving treatments, people aren't gonna get it. We're not going to make change in our own backyard in Virginia with those numbers that I showed you at the beginning of the talk. And so that is the number one thing. So I end on this note because no matter who you are, where you work, you know, what role you play and what team you are with, we all can play a role in this no matter what you do. And so our words matter, and I really, really emphasize this too with my clinical colleagues, because there's something about when you go to the doctor, then they say something, you remember those words, right? My doctor told me to do this. My doctor told me that this is bad for my health. That our words really matter. And sometimes I have to admit, we forget that as physicians, because we're people first. We're human beings, and then we're physicians second. But our words really matter. And when we're talking about addiction and we're talking about life-saving addiction treatments, we have to make sure that we are paying attention to our language. And I really emphasize this, especially with my clinical colleagues. And so using person-first language, especially for my colleagues who do not have lived experience with the disease of addiction, I say it's extremely important that we do that. And so if you want handouts, if you want references in order to bring back to other people that you work in, this is the place to go. So this is just a snapshot of 2 handouts that are free online. I actually require every medical student, every research assistant, every undergrad student that wants to shadow, et cetera, to review these handouts and review what person-first language is from the setting that you are the medical trainee in my clinic, where we prioritize recovery-oriented, trauma-informed, compassionate care for people who are seeking treatment for substance use disorders, especially during pregnancy and the postpartum period. And I'm going to end with some more quotes from my patients, and thank you for your time.